Good mo- Hi.
Well, good morning, everybody. My name is Trevor Schell, and I'd like to welcome you all to OHCOW's 26th annual RSI webinar series, focused on the recognition and prevention of musculoskeletal disorders. RSI Day has grown to become the world's largest ergonomic-focused webinar series, which is illustrated on the map you're seeing on the screen right now. Today, we have unique registrants from a record-breaking 57 different countries. Each year when I'm reviewing the registrations, I can't tell you how excited I get when I see a person from a new country registering. When we began RSI Day locally, we had 20 people in the basement of a local union hall. And from that, it's grown to become a truly global phenomenon. You will notice a series of questions that will be popping up on the screen. It's imperative that you complete these questions, as we're mandated to ask them on behalf of our funder to demonstrate the benefits of offering such a webinar series. There will be a series of pre and post questions that we desperately need you to complete. The session is being recorded and will be uploaded to our YouTube channel in a few days. You'll receive notification once it has been uploaded. We ask that everyone remains muted for the duration of the webinar, and failure to do so can result in your removal from the session. If you have any questions for the presenters, please ask them in the chat, and they'll be monitored by my colleague, Dwayne Fuchs. Now, our first presentation today is a joint presentation with myself and OHCOW physician, Dr. Cynthia Arnold, on osteoarthritis of the CMC joint. Just give me 1 second while I switch over. Tony, can you see everything okay?
I still see the map.
Just give me 1 second. Good?
Yes, that's good.
Okay.
So good morning, everyone. I'm excited to be here to talk about osteoarthritis of the first carpometacarpal joint. During the talk, I'll refer to this joint as the first CMC. And if I just say CMC, then you know I've made a mistake because we're talking about the first. Next slide, please, Trevor. So today we'll present a case of first CMCOA that Trevor and I worked on. Then I'll go over the anatomy of the joint so that we're all on the same page and understand what we're talking about. I'll discuss OA and specifically first CMCOA. I'll go over the non-occupational risk factors, and then Trevor will discuss the occupational risk factors. Next slide. So we had a 53-year-old male sheet metal worker who presented with approximately 32 years of experience. He presented with severe pain of his right thumb and wrist, and after about a year and a half, started developing some difficulties with movement. He was seen by his orthopedic surgeon who diagnosed first CMCOA. He underwent x-rays and ultrasounds which confirmed the diagnosis. He was treated with thumb splint, nonsteroidal anti-inflammatories, and underwent a steroid injection, which brought him about 9 months of relief. Unfortunately, repeat injections, and I think he had 3 to 4 over a year and a half, 2-year span, had much shorter duration of relief, and his orthopedic surgeon referred him on to a plastic surgeon for surgery. Next slide, please. So this is the bones of the hand. I think the one on the right is the best one to look at with the hand flat. We can see that the fingers have 3 phalanges. The thumb has 2. Then we go down into the long bones of the hand, which are the metacarpals. And then we come to the 8 carpal bones that make up the wrist. And we can see the first CMC joint as it's in that circle and it's highlighted. And we can see that it's at the base of the thumb. Next slide, please. This is just a better view to look right at that joint. In the green, you've got the first metacarpal of the thumb. You see the trapezium, which is the carpal bone, and then the joint there. Next slide, please. So this, the green in this is the articular cartilage. The long bone or the first metacarpal is seen there. And then it butts up against the trapezium. And then behind that, you see the scaphoid bone. And when we talk about CMC joint OA, it's the joint between the first metacarpal and the trapezium, but it also can include the scaphoid trapezium joint if there's arthritis there. Next slide. This slide just outlines the blood supply, and it's a simplistic view. The blood enters the hand from the ulnar and the radial artery, with the radial artery on the right side by the thumb. On the thumb. The blood there, the superior palmar arch forms from the ulnar artery with contributions from the radial artery, and the deep palmar arch there is a continuation of the radial artery with some input from the ulnar artery. The thumb has dorsal and palmar systems. Both systems can supply the thumb with enough blood supply on their own. And you won't be surprised to find the dorsal system, it's the dorsal ulnar and the dorsal radial artery. And in the palmar system, it's the ulnar digital artery and the radial digital artery. Next slide. This is one of my favorite slides because it shows all the functions of the first CMC joint. So if you move your thumb around, you can see how many positions it can go in. So it's not surprising that severe pain from OA results in significant loss of hand function. I think people often underestimate the impact of hand OA in an individual. We're always focused on lower limbs, hips, and knees. But obviously from this anatomy, you can see that damage to that joint would result in difficulty in doing a number of activities of daily living. Next slide. So what is osteoarthritis? It is the most common cause of arthritis, and according to Johnson Hunter in 2014, 15% of the population has OA. Pain is a common presentation, often involves multiple joints. The inflammation seen with OA is modest compared to the inflammatory arthritises such as rheumatoid arthritis, psoriatic arthritis. We see changes to bone, ligament, cartilage, and synovial tissue. So you get narrowing of the joint space, loss of articular cartilage, osteoformation. Next slide, please. So when we look at first CMC OA, the hand is one of the most common sites of arthritis in the body. In 12% of individuals over the age of 50 in the UK have pain in their hands from arthritis. The first CMC joint is the second most common site of arthritis in the hand, and it is responsible for more pain and disability than other sites in the hand. This joint can present alone or it can present in association with other arthritis in the hand. And what are the symptoms? People usually present with pain at the base of the thumb. It's aggravated with movement of the thumb, such as pinching and gripping. So if you can imagine if they're using scissors or twisting off bottle caps or opening a jar, there'd be significant difficulty and pain. With progression, with osteoarthritis, the pain develops thumb weakness, decreased range of motion, and go on to mechanical instability. Next slide. So how do we diagnose this? Start with a clinical diagnosis, the history, just what we discussed. Where is the pain? What are the aggravating and alleviating factors? On physical exam, where is the patient tender? Is he tender over that joint? Is there any swelling? What is the range of movement of the thumb? Is there any weakness? Can you feel a bogginess in the joint? Is there an effusion? Some people think that a clinical diagnosis is enough, but if we look, most people go on to x-rays. And O'Neill and all in 2018 said that up to 50% of people had radiographic changes of osteoarthritis somewhere in their body, but they were asymptomatic. When we look at the hand, 21% of the US population has radiographic evidence of OA, but they don't have any symptoms. 16% have x-ray findings and symptoms. When we look at the first CMC joint, there's a higher association between x-ray findings and the person having pain and decreased strength. In the past, over the past 10 to 20 years, MRIs and ultrasounds have been used more. MRIs were initially just a research tool. And because of the use of MRIs, we know that most CMC OA is associated with ligament rupture and dorsal subluxation. In our case, our patient had moderate to severe OA of his first CMC joint with minimal OA in the rest of his hand. But his ultrasound showed a joint effusion and he did have subluxation. So next slide, what is the treatment? You know, we always like to avoid surgery, especially in elderly and people with comorbidities. So if we can avoid surgery and do a conservative treatment, that is preferred. Physio is popular and there's some good evidence that it helps with pain in the first CMC joint. You can try oral and topical non-steroidal inflammatory drugs, Tylenol for pain. Thumb splints are good at improving pain, but unfortunately they decrease the function of your thumb. And steroid injections have good evidence of working, though there was one study that showed they didn't think it was any better than placebo. So when we have failure of the conservative, we go on to surgery. Next slide. And the primary goal with surgery is pain relief, but they also want to try and preserve some of the function. Occasionally they do a bone fusion, but most of the procedure, all of the procedures usually involve partial or complete removal of the trapezium. And they usually combine this with another procedure to try and save the joint space, such as ligament reconstruction and tendon interposition, an LRTI. If we look at what was done recently in the US, 93% of the US surgeons performed a trapeziectomy with pinning with an LRTI. It's considered a low incidence of complications, though of course there's always the risk of infection or the wound opening up or a complex regional pain syndrome or injury to the radial nerve. But basically the surgeon and the patient decide the procedure. And they say one of the risk factors for someone not going to succeed with surgery is not going to succeed with a non-surgical intervention. A conservative intervention is a subluxation like our patient had. Okay, the next slide. So today, the current evidence in the scientific literature opines that it's the interaction of each individual's unique risk factors that results in the development of OA. So when we look at non-occupational risk factors, there's no doubt that age is the strongest predictor of OA, but no one's 100% sure why that is and what the mechanism is known. Females are much higher risk of developing OA of the hand, with a maximum 4-fold increase compared to males between the age of 50 and 55. In females, the risk peaks at the age of 55 to 60 and then decreases. When we look even at the age of 85, there's still a 2-to-1 female to 1 ratio. Johnson and Hunter in 2014 looked at the Framingham study, and they found symptomatic hand OA was present in 26% of women and 13% of men. And in 2022, Raj and al. Looked at the age-adjusted prevalence, and they said 17% of men get first CMC joint OA versus 15% of women. So they were actually looking at our specific joint. Why does this happen? No one knows. Some people think it's the role of estrogen, but that hasn't been proven. Bone strength, the size, the ligament laxity, pregnancy. The bottom line is no one really knows, but it is a major risk factor being female. Next slide. When I look at obesity, it's very controversial. There are some good evidence that there is association between obesity and hand OA in recent um, studies, and they think it's secondary to metabolic and inflammatory factors such as metabolic syndrome, diabetes. But for everyone that says there's an association, there were many that showed no association. So I think I'm sitting on the fence on this one. I think the literature, it's up in the air. The one thing everyone does agree on is that approximately 60% of hand OA is secondary genetics. They also agree that previous trauma, such as the fracture, can result in OA developing later. Next slide. So in summary, there are factors we can't change. You can't change your genetics or being female, but there are factors that can be modified, such as environmental factors, such as work life. And all these factors interact to result in first CMC joint OA. Wigley et al. In 2011 discussed the misuse of the term degenerative, and he did this regarding a number of disorders, including osteoarthritis. Their philosophy was that insurance company used the term degenerative to mean age-related and to deny patients' claim. And our patient was complained, and part of their stance was it was degenerative disease. It wasn't work-related. So Wigley and all feel that risk factors such as sex, age, and genetics can predispose you to an injury, but an accident or an environmental change is necessary to cause the injury or the start of the development of osteoarthritis. So now we will have Trevor discuss occupational risk factors for first CMCOA and see if the patient's work history as a sheet metal worker contributed to his development of this arthritis.
Great, thanks. So starting off with the occupational risk factors, grasping a strong pinch grip is actually one of the main risk factors that we tend to find related to CMC joint OA. This is because a pinch grip using the index finger and the thumb places a high degree of force on the CMC joint ligaments. Studies have shown that the force increases exponentially between the force exerted at the point of the fingertip of contact and at the CMC joint. As a matter of fact, it's actually 12 times greater at the CMC joint compared to the force you're exerting on the object itself. So, for example, if someone was exerting 10 kilograms of force exertion pinch gripping at the fingertips, there's actually the equivalent of 120 kilograms of force being exerted on the CMC joint itself. Gilbertson et al. Sought to establish normative data for adults between the ages of 19 and 92, comparing pinch and power grips. Regardless of which hand they were looking at, what was found was that the power grip was actually 4 times greater than a pinch grip. So by using your whole hand, you're generating 4 times the amount of force than using a pinch grip. They also found that using a pinch grip only allowed for about 25% of maximum grip strength to be generated compared to a power grip. Other awkward risk factors are awkward postures, for example, with adduction. So basically, in a pinch grip, having your thumb and your index finger squeezed together. This causes a slight change to the orientation of the bones, so they don't fit as well together. And there's more strain on the joint and the ligament itself compared to, say, abduction, where there's actually sort of, like such as grasping the larger book, where there's more space between the thumb and the index finger that allows that normal orientation of the bones to be maintained. Another risk factor is inadequate recovery, formerly known as repetitive motion. When Zeller, in 1996, stated that the thumb provides a stable post about which the rest of the hand may perform activities of a pinch and grasp. The special functions of the thumb can account for up to 50% of their overall hand use. Exposures to twisting, jamming, and contusive forces, as well as repetitive stress, is an everyday occurrence in the workplace. So this goes back to that sort of range of motion that Dr. Arnold was talking about at the beginning, that there's just, the thumb is so involved and so has so many different roles to play that, again, it accounts for 50% of our overall hand use. Also, overall, repeated forceful manual tasks will diminish the worker's ability to produce the required force like gripping. It also increases the risk of fatigue and injury. Continuous use of the hands and wrists will result in fatigue of the muscles. In turn, this reduces the muscle's ability to generate the maximum amount of force required to perform essential tasks. If a muscle group is not given enough time to recover between repetitive or continuous motions, muscle and joint soreness can escalate, leading to a cumulative trauma injury. And Nocella in 2011 stated that prolonged muscle activity leads to a reduction of mechanical power and force output, which is commonly indicated as muscular fatigue. The development of muscular fatigue during repetitive stimulation of the skeletal muscle consists of an initial phase during which the force will decrease by about 10 to 15%, followed by a second phase where the force remains almost constant, and then finally, the final phase where the force begins to drop to low levels. Now, static postures are another risk factor. Now, as Dr. Arnold mentioned at the very beginning, the CMC joint is an area of very low blood flow. Nutrients must enter the cartilage from the bone or from the synovial surface surrounding the joint. Static and often awkward postures reduce the blood flow to synovial tissues and also reduce synovial fluid circulation to the CMC joint. This results in less penetration of the cartilage by solutes and reduces the clearance of waste products from the joint, which highlights the dependence on normal loading patterns for the maintenance of a functional component. Tissue discomfort and fatigue will also often arise from having to hold the tense muscles in a fixed or awkward posture for prolonged periods. The cartilage doesn't have any capillaries. It receives its nutrients again from the synovial membrane. And the transfer of nutrients occurs when pressure is being placed upon the joint and during normal movements such as flexion and extension. Under pressure, the synovial fluid inside the cartilage is forced out, carrying debris from the cartilage. And as pressure is relieved, the synovial fluid will seep back into the cartilage, providing it with nutrients. It's very similar if we were to squeeze a sponge that's in a bucket of water. As you squeeze the sponge or apply pressure, water is sort of flushed out of the sponge. When you release it, water will seep back into the sponge. During static postures, the selected joints are placed under pressure for a lengthy period. Since the articular process main function is to absorb compression, it is forced to work the entire time, making it more susceptible to softening and degeneration. So this results in the bones having to absorb more pressure and increasing the risk of deformation and bone spurs. Also, as there is no pressure change during a static posture, no nutrients are being delivered to the cartilage. Therefore, no repairs can be made, which may increase the severity of damage to the cartilage. Another risk factor is contact stress. When gripping tools such as snips, shears, pliers, the point of application of the force is mainly directed directly over the CMC joint itself. very much like acting like a constant trauma to the joint. This not only applies direct pressure to the joint, but also onto the few blood vessels passing within the space. As previously mentioned, reduced blood flow has been linked to the development of osteoarthritis, especially with a joint such as the CMC that already has limited blood flow. Now, gloves, while providing protection from the elements and sharp metal, have several associated problems that have to be considered. If the gloves are too large, then a worker will often grip harder to hold an object, thereby causing more strain on the muscles. If the gloves are too small, they'll constrict the blood flow into the hands and apply pressure onto the nerves. This leads to reduced blood delivery to the muscles and numbness of the hands. Gloves also reduce the tactile or feeling sensation that one experiences when touching an object. As a result, the worker is required to squeeze harder to ensure they're grasping their equipment. As a result, exerting more force to perform the task places them at a greater risk of injury. Continuous exposure to vibration can also have multiple effects on the hand. The first being that vibration has been shown to have an effect on skeletal muscles such as tendons and nerves, or tendons and muscles. These effects cause local contraction of the muscles that are in contact with the vibratory source, such as a tool handle. That leads to muscle fatigue as the result of overstimulation. These contractions also lead to attenuation of the vibration signal to the affected areas. So when operating vibratory equipment with tense muscles, this can lead to an attenuation or amplification of vibration into the body. Now, Elsner in 1995 attempted to show the interaction of the majority of the risk factors on the development of osteoarthritis. So you can see on the left, we have hand-on vibration. The effect of low frequency percussion causing that sort of constant contractions of the muscles. On the other side, the normal risk factors we talked about, inadequate recovery, microtrauma, awkward postures. These all act to cause dynamic and static joint loading, as well as the effect of low frequency percussion, and add to that these sort of non-occupational factors that Dr. Arnold mentioned can all lead to contribute to the development of osteoarthritis. Now, with respect to prevention of injuries, each time someone experiences thumb pain when doing an activity, they need to stop and consider whether the way they're doing it is causing stress on the joint. They need to take notice of any pain they feel. It can serve as a warning that the way they're performing the activity is causing damage to the joint. For example, using a pinch grip when you're writing. One way that people can prevent stuff is to keep the top of the joint of the thumb bent and the wrist extended. For activities that involve turning or twisting, avoid fully straightening the top of the joint of the thumb and also the thumb crossing into the palm, which is that adduction that we talked about. Staying that abduction is beneficial. Spreading the load over several joints, again, carrying an item on two hands instead of one, and using the stronger joints rather than putting the strain just on the thumb joint. So again, using that power grasp instead of the pinch grasp, because again, it's 4 times stronger. An example of joint protection, carrying a coffee mug. Instead of just carrying the mug with your thumb, hold the mug with one hand and support the base with the other. There's going to be less strain placed upon the CMC joint. Another example is carrying a bulky item such as a pile of papers. With just one hand, we've got that large squeezing force happening. Instead, use 2 hands or hug it to your chest. So therefore, you're putting less strain on the joint. There's assistive devices for writing, because one of the most common things we do see pinch gripping used is when we're writing. So they have larger diameter pens or pen grips that all act to reduce the impact of pinch gripping. So while pinch gripping is still happening, it's actually spreading your thumb and index finger apart to get more of the abduction going on at the thumb as opposed to the adduction. It's also been shown that felt and gel pens actually require less force to write than a ballpoint pen. There's also other sets of devices around the house that people can use: an electric toothbrush instead of a standard toothbrush, a wider utensils, or placing foam around utensils to increase the diameter. There's a device called a button hook that instead of using that pull-on pinch grip to feed the button through the hole, you loop it around the button and pull it through the hole. And then other devices such as jar and bottle openers. With respect to tool design, you want to make sure you purchase tools with a wide handle diameter to avoid pinch gripping. Spring-loaded tools will help to reduce the force you have to exert. Rubber handles to avoid pressure points. You also want to make sure that the handle of the tools have the appropriate handle span for your hand size. As shown in the chart on the slide, as with awkward postures, the design of tools can also impact muscle force generation. This is illustrated by the effect of handle span on the ability to generate an effective grip strength. When the size of the hand and the span of the tool were compared, there was a large difference for the maximum amount of grip strength that the subjects could perform: a small hand about 200 newtons and a large hand about 450. There was also a large change within the hand sizes. For example, with a small hand, the maximal grip strength was attained with a handle span of 5 centimeters, compared to the larger hand, where the maximal grip strength occurred with a handle span of 6. Now, let's go back to our case study that we were talking about with our 53-year-old sheet metal worker. Bottom line, his compensation claim was denied because the ongoing diagnosis of osteoarthritis is degenerative in nature and therefore not compatible with your workplace injury. Well, let's look at sort of what he was doing for his job. The primary tools used by a sheet metal worker include shears, which are used for a long, smooth, or have a long, smooth cutting blade used for large cuts and are used to cut thicker or longer pieces of metal and are used for about 35% of the day. They also use snips, which are shorter and often have a serrated blade for smaller cuts and are used for fine, short, or curved cuts, often on thinner metal. They tend to leave jagged edges, which must also be smoothed with a grinder. They come in multiple designs for straight, left, or right cuts, and again, they're used for about 35% of the day. A grinder is used to smooth jagged edges and can be used for up to 25% of the day. And then other tools such as hammer drills or hammers are used for about 20% of the day. Now, what can become very evident very quickly about the tools, the snips and the shears, is that they're being held within the hand, a very common factor between all of them. So when being used, the pressure and application force occurs again directly at the CMC joint. So all the effort of squeezing, cutting, is applied directly onto the CMC joint, which again is 12 times larger at the joint than where the tool is actually being used against the object itself. A review of the patient's physical demands analysis basically resulted on average of risk factors using the upper limb, dynamic pushing and pulling force for about 35% of the day, hand gripping for about 83%, pitch gripping for about 40%, upper extremity coordination, 84%, vibratory exposure, 50%, and also glove use for about 100%. Additionally, from the previous slide, that direct forceful application of using those hand tools would have occurred for roughly about 84% of the shift as well. Cynthia?
Yes, if we look at this case, it's hard to change the WSIB's view that OA is secondary to age alone. But the evidence shows it's multifactorial. I mean, you look at this guy, he wasn't female. He was relatively young for a male to develop hand OA. We don't know about his genetics, but his main risk factor was occupational risk factors. If you go, I think there's one more slide, Trevor, if you could go to it. I like this quote from Johnson and Hunter. It says, OA appears to be the result of a complex interplay between mechanical, cellular, and biochemical factors that lead to a common end-stage pathology. As such, a different set of risk factors acting together may cause OA onset in any given individual. And we certainly see here with this patient that he had occupational exposures that contributed to his OA. And I think in these cases, it's the ergo report that's invaluable. We may not be able to change WSIB's, calling things only age related, but when you see an ergo report pointing out his job and what's involved, I think it helps a great deal. And I hope his appeal gets accepted.
Excuse me.
And that's all I have to say.
Dwayne, any questions?
So you guys are ready? Okay, good. Thank you, Dr. Arnold and Trevor. Yeah, there's a few. So the first one is pertaining to genetics. Are there certain ethnic groups where OA may be more prevalent?
Yes, there are. They show that a lot of, I think I have it here, that the Japanese have less pain than Americans. And there is some evidence that Chinese have less pain as well. But when you look at genetics, they tend to say that it's a genetic variant, an ACAN, and an HFE that results in it.
Okay, thank you. So next question, is there any research on straight versus back bending thumb bracket genetics and how this relates to the injury and the force generation? I'm not really sure, but that's what the question was written. Do you guys understand that?
I'm kind of confused.
Is there any research on straight versus back bending thumb? And how does that relate to injury or force generation?
Back bending. I didn't come across anything regarding the thumb bending backwards. It was just on the abduction and the adduction of the thumb itself.
Yeah, when I look at genetics, they said, even for like ethnics and populations, they don't really have a good assessment of controls in the studies. And other than coming across some of the variants, they haven't really said much more than that with respect to the hand. And I certainly could look more into that.
Okay, thank you. Trevor, this might be for you. What would the required rest period be to potentially avoid repetitive injury? I'm assuming it's directed towards the hand and the thumb here.
That's the magic question. I mean, we really don't know. I mean, with almost anything, we know a work rest cycle, how much, how little, that's yet to be determined with almost any aspect of injuries as well as prevention. And I think something that definitely has to be researched in more detail because, and again, everyone's so different with individual susceptibilities, you know, different hand size, etc., different tasks that you're doing, different occupations, the amount of force being exerted, the amount of pressure being applied, that there's so many variables that I don't think there's a magic number. The bottom line is once you start experiencing fatigue, discomfort, uh, that's when a great sign you need to take a break. I mean, for example, the one I can do is I was installing a new light the other day, working up on a ladder, my hands up overhead, and as per always, there was something that could have gone wrong. It went wrong. Arms were up overhead longer. I had to stop and take a break because the shoulder pain was getting so high. So once you start experiencing any sign of that beginning of discomfort, that's a good sign you need to take a break and allow for some recovery.
Okay, thanks. That probably is very similar to this question. Are the principles of static posture / position or the lack of ability to regenerate applicable to static postures and position elsewhere in the body?
Absolutely. A prolonged static awkward posture is going to reduce blood flow to the muscles, the tissues, the joints, the cartilage, etc. No matter what part of the body it is, there's always the effect of static awkward postures on the reduction of blood flow and impingement of nerve supply going into the body.
Okay. Is there an amount of pressure that has been quantified to result in full compression of the cartilage, similar to the sponge being similar to a sponge being fully compressed with no or minimal liquid remaining?
No, because that would kind of go against any form of ethics for research. Because and then cadaver studies aren't going to yield any useful results because the tissue is already dehydrated, and also would be in an elderly person. So no, there isn't any magical number.
Okay, Dr. Arnold, anything to add to that, or are you good with that?
I have nothing to add.
Okay. Next question. Based on the findings, would the holding of a knife with the thumb remaining straight reduce the risk or the onset of OA symptoms? Do you understand what I'm thinking? Yeah. It would be without wrapping it around. That's my thought. I don't know.
Yeah, I mean, it depends on, again, sort of if we illustrated the thickness of the knife itself, whether or not there's adduction of the thumb happening.
Okay.
Would it be functional that way, Trevor?
I think so. Again, depending on the handle size, right? I mean, if you're doing very precise paring with a small knife, you're going to be getting the adduction. Something more larger with a larger knife, with a larger handle is going to make it easier. I do know that, like, when I'm in the kitchen chopping and dicing and stuff, I do try and maintain almost like not quite a pinch grip at all. I've got my thumb on the side of the knife and my index finger more on the top of it. So there's less gripping going on, and it's more just transfer it more to the wrist than actual the pinch gripping.
Okay, is there a relationship between vibration and the first CMC joint OA symptoms?
Oh, well, again, the effects of vibration happen in almost any joint of the body that comes in contact with direct vibratory sources. So in our case study, the gentleman using the grinder, there was exposure of the hand, the CMC joint, which again will cause that cutaneous contractions of the muscles, leading to fatigue, which then leads to reduction of grip strength, as well as reduction in blood flow and nerve supply on the tissues within the area.
Okay, just one more last one that was inserted. I'm assuming somewhere around when you guys were talking about research. It was asking how the data, if you knew how the data was collected.
For which part?
Like I said, it was about halfway through.
Yeah, because I mean, there's so many studies out there, right? So to know how they're collecting the data, it's not sure which study they're referring to directly.
Yeah, I can't figure it out. That's why I was waiting. I couldn't figure out exactly where that was, but okay. So that's that's it.
Perfect.
That's it for questions. Thank you, Trevor and Dr. Arnold. That was fabulous. Go ahead,
Awesome.
Trevor.
Okay.
When's the next one starting?
Okay. Well, I'd like to introduce our second presenters. Today, it's going to be another joint presentation between my colleague, Melissa Statham, and another one of OHCOW's physicians, Dr. Pravesh Jugnundan, on osteoarthritis of the hip.
Hi, good morning. Thank you, Trevor. Hopefully everyone can hear me.
We can hear
Trevor,
you fine.
thank you for the invitation, and I thank Melissa, my co-presenter, for inviting me to present with her. My role is to do just the overview on the anatomy, physiology, and some of the pathology. What you will hear is that the pathological mechanisms are similar to what was discussed earlier on in the earlier presentation. So I won't spend too much time on that. I'll touch on it. But so osteoarthritis of the hip, why is it important? Because it affects our mobility and quality of life. So that's the basic thing. It affects your mobility and quality of the life. So this is the anatomy of the hip. It's made up of the pelvis and the femur. So when you're standing and you hang your hands down, it's the two joints on either side that allows you to walk. It's a pelvis, it's a acetabulum, and the femur bone. Next slide, please. That's just a schematic of the same thing, so it gives you some perspective. So the next slide demonstrates the joint as a ball and a socket joint. The socket is, if you just think about, a round ball and you cut it in half, that empty space is the socket, and the ball is a normal ball that fits into this. Next slide. An everyday example of a ball and socket joint is what we have in our bathrooms, is the shower head. And we all know that this is a very highly mobile device. You can move it almost in any direction. And that's a ball and socket joint. If we go to the next slide, it gives you a detailed view of the pelvic bone showing the acetabulum. This is the cup that's lined with cartilage. The next slide shows you the long bone in the thigh. That's the femur. And the ball is at the top end, the head of the femur. As you track down, the distal end of the femur articulates at the knee joint. So the femur connects at the top with the hip joint and at the bottom with the knee joint. This is important because anything impacting one joint is more likely to impact the other joint because the mechanisms all changed when either joint is not functioning well. In the next slide, we will see that the ball and the socket are covered with articular cartilage. This is, as was discussed previously, a slick, spongy covering that allows one side of the joint to slide against the other joint surface easily. The fluid between both these cartilages, synovial fluid, think about grease in the pistons, in your car pistons, that allow it to flow very freely. And as we previously heard, there's no direct blood supply to the cartilage. The blood supply comes via the bone and it soaks through from the inside tuberculi. The nutrients come from the synovial fluid that lines the joints. So therefore, because there's no direct blood supply, we find that the cartilage has limited capacity to repair. And once it's degraded and lost, it's not replaced to any measurable degree. So being a ball and socket joint, as I said, this is highly movable in all directions: forward flexion, backwards extension. Turning your foot inwards is internal rotation. Turning your foot outwards is external rotation. Moving your leg away from the center of the body, abduction. Moving your leg towards the other leg, adduction. And we often see when we watch gymnastics or dances, highly flexible hip joints. So when we have a patient with hip pain, what is our differential diagnosis? So there's many things, and obviously the age of the patient makes a difference. And some of the things we think about commonly is a trochanteric bursitis. Usually they will present with pain on the outer aspect of the hip. This is inflammation of the bursa. It's where the tendon slides over the joint. And because of some unusual or repetitive movement or direct trauma, the area can become inflamed and can cause hip region pain. Inflammatory arthritis, for example, rheumatoid arthritis, you can get pain in any joint. A septic joint, this is obviously something quite important and urgent that needs treatment. Typically, the joint will be red, hot, swollen, and the patient themselves may have a fever. So this is something you want to diagnose very, very early and treat them promptly. Osteonecrosis is destruction of the hip joint, usually in the younger patient where the blood supply is compromised. Femoroacetabular impingement, also where the foot of the head and the acetabulum is not correctly aligned. Again, this tends to be in the younger population. Crystalline disease, for example, gout. Lumbar radiculopathy and lumbar spinal stenosis. So basically what's happening here, we are getting referred pain from the low back region, either pressure on the sciatic nerve with lumbar radiculopathy being transferred to the hip joint, or pressure on the spinal cord itself being radiating to the hip joint, either one or both joints. Obviously, we're worried about cancer. This could be a primary bone cancer in the region, or a soft tissue cancer, or it could be a metastatic cancer, for example, cancer that spreads from the bowel or the lungs to the bone, and that could be your first presentation. Meralgia paresthetica, this is pressure of the superficial nerve in front of the thigh. Typically, the pain is in front of the thigh. It could be a numbness pain, tingling, related to direct pressure. So, workers with tight belts, or if you put on lots of weight, or your job involves, forward bending constantly and applying pressure in this area. Iliotibial band syndrome is pain on the lateral aspect, outer aspect of the hip, very similar to trochanteric bursitis, just extending further down. Vascular claudication relates to the blood supply in the area. Usually these people will have multiple other medical issues, for example, diabetes, high cholesterol, etc. So in hip osteoarthritis, this occurs when the cartilage in the hip joint wears away, leaving less protection for the bones. As the unprotected bones rub together, they can damage each other, causing pain, inflammation, and stiffness. Ultimately, the joint will fail, limiting mobility. Generally, 1 in 4 people will develop hip osteoarthritis by the age of 85. The risk of osteoarthritis is similar for people of different races and sexes. The condition occurs most often in older patients, but younger patients can develop hip osteoarthritis, usually after a joint injury. Although destruction and loss of the articular cartilage is a central component of osteoarthritis, all joint tissues are affected in some way. This indicates that osteoarthritis is a disease of the joint as an organ. So more than the bone and the cartilage, they are talking about the synovial fluid, the ligaments, the tendons, and the muscles. So everything around the joint gets affected. Stage 1, you may not even know you have the disease or the condition. You may have no symptoms. If At worst, you may have little pain or stiffness for a short while. There may sometimes be a bony spur, and osteoarthritis can affect one or both hips. Usually the x-rays, if done, they do not correlate to function or pain impairment experienced by the patient. So what you see in x-ray does not always correlate well with the level of pain or level of function that you see. In stage 2, this is mild hip osteoarthritis. You are more likely to experience hip pain and stiffness, especially in the morning or after sitting, that is a static posture. Initial steps may be difficult, but the pain usually subsides once you start moving. Once again, x-rays may show some bony spurs, but the space between the hip joints is still adequate. In stage 3, which is moderate osteoarthritis, you're more likely to experience more pain and stiffness, especially when you start moving and with activity. Going up the stairs or downstairs or standing for long periods or walking for long periods can be bothersome. Prolonged activity leads to more swelling and inflammation due to larger bone spurs, eroded cartilage, and more narrowing of the space between the hip bones. Sometimes you may hear patients complain of a popping or snapping sensation. Stage 4 is severe osteoarthritis. There's gross loss of joint space with sclerosis and cyst, marked deformity of the femoral head and acetabulum, and large osteophytes. There may be constant pain, stiffness, even when you're not active. The pain can be severe. The pain can disrupt your sleep. So this is end-stage joint disease. The next slide just demonstrates x-rays that shows, normal joint space, and the one on the right showing you an osteoarthritic joint. So in terms of symptoms, there could be swelling, tenderness, grinding or crunching sensation, pain in the groin or the thigh that radiate to the buttock or the knee. So the pain doesn't have to be localized. Pain that increases with activity, stiffness of the joint that makes it difficult to walk or bend, locking or sticking sensation, decreased range of motion that affects walking. It may cause limping, increased joint pain, usually in damp and cold weather. So how do you diagnose osteoarthritis? Usually the first thing is on your history. You want to know what's the nature of the pain. Is your pain intermittent? Is it constant? What aggravates it? What improves it? You want to know if there's any specific trauma. Obviously, the age group of presentation is directs your history. I mean, a younger patient versus an older patient. Older patient is more likely to have osteoarthritis. During your history taking, you want to exclude other important medical issues, for example, an infection. You want to exclude cancer. Is it a primary or secondary cancer? You don't want to miss these things. You want to exclude other inflammatory conditions, for example, rheumatoid arthritis, psoriatic arthritis. You want to exclude referred pain to the area. Is this pain coming from the lumbar spine? Is this pain related to the trochanteric bursitis? So the history is of vital importance. Typically, in a medical evaluation, the history guides your physical examination. So your physical examination is more to confirm your suspicion already made after you've done your history. And it's to find other unusual, unexpected things when you do the physical examination. So during the physical examination, there may be decreased range of motion, there may be tenderness, active and passive range of motion may be decreased, there may be crepitus, there may be pain when you put pressure. You'll have to look at your patient walking and the gait may be altered. So once you've done your examination, you'll want to do imaging studies. Usually the imaging study of choice is an X-ray. X-ray is quite a good first-line tool. Nowadays, we have much more readily and quicker access to ultrasounds. So the ultrasounds is also important to exclude your trochanteric bursitis or any muscle tears or ligament inflammation in and around the hip joint itself. But obviously, if you're highly suspicious that it's osteoarthritis, and if that's confirmed by your X-ray, that's where you're going to stop. Sometimes, like I said, the X-rays may not always correlate well with the patient's symptoms, and then you may need further studying, for example, a CT scan or an MRI. Non-occupational causes, these were discussed earlier. Gender, the older you get, the more likely you to have osteoarthritis. Sexual occurs more in females. Osteoarthritis affects about 10 or 25% of the adult population at 60 plus. Family history is important, tend to run family. Obesity, there's more stress on the weight-bearing joints, both the hips and the knees. And we think that obesity may also lead to inflammation, and the inflammatory process may cause joint damage. Obviously, a history of previous injury is important. Joint malformations, usually in the younger people. Lifestyle is important. A sedentary lifestyle, static postures in the joint all the time, or high impact activity. Other diseases, rheumatoid arthritis, gout, can result in osteoarthritis. Overview on treatment. So basically, when it comes to treatment, your aim of treatment is decrease function, at least decrease pain and increase function, improve quality of life. So whatever you do in treatment, the goal is to improve the quality of life. So you don't want to offer someone that has a very poor quality of life, that's kind of bedridden or wheelchair bound, any significant treatment of the hip, because you're not going to do anything with the quality of life. So for the average person, increase function, decrease pain, improve quality of life. First line treatment is education. So you want to educate the patient about the disease, the prognosis, the progression, etc. Physical rehabilitation, working on an exercise program with a physiotherapist that's goal orientated, is very important. This helps to strengthen all the muscles around the hip joint. It helps to improve function and decrease pain. This should be a formal program with specific outlines and specific goals. Assistive devices are important. You may need a walking stick or walker to help you along. So that is the first line treatment, is education, non-pharmaceutical, which is your assistive devices, physical therapy, activity modification. For example, if your patient is involved in high impact sport, you want to probably tell them, you want to give up long distance running, maybe you want to do swimming or cycling, which is less impactful on the joint. So conservative management first. The second line treatment is pharmaceuticals, over-the-counter Tylenol, anti-inflammatories taken on a regular basis. That's if first line failed, then you're going to move to medication. You can move to prescription anti-inflammatories on a more regular basis. And either that works or doesn't work. If that doesn't work, cortisone injections, ultrasound guided cortisone injections into the joint has proven to be helpful. It gives you more time before you replace the joint. So it buys you some time. It's not going to prevent the process and an eventual joint replacement, but it's a stopgap, and it improves quality, gives you enough time. Viscous supplementation in injections into the hip joint has been found not to be helpful. So cortisone is the only thing. And if that fails, then it's a referral to an orthopedic surgeon for considering of a hip replacement. And this is a schematic of what I just discussed. So in the next slide, in terms of hip replacement, you can have a total hip replacement where the damaged part of the hip joints are replaced with artificial implants made of metal, plastic, or ceramic. You can have hip resurfacing. The damaged surface of the hip joint are removed and replaced with metal in order to restore joint function. Osteotomy is where the bones of the hip are realigned to redistribute weight and reduce stress. The osteotomies are usually, there's not a good fit between the ball and the socket, seen in younger patients. So they will realign this where the fit is better. The next is just a diagrammatic representation of a hip replacement. You can see both the cup and the ball is replaced, and the ball is anchored with a large screw going into the femur. On the right is a total hip replacement, and on the left is hip resurfacing. And the next slide is also just some, imaging studies of hips that literally been screwed on, and exposes the surgeon to lots of hand arm vibration when they're drilling and hammering into your body to do all these things. So that's my overview of just some of the anatomy and physiology and a little bit of the pathology. Hopefully helpful. I'll hand you over now to Melissa.
Thank you
very much.
Pravesh. I'm going to address now more of the occupational causes for hip osteoarthritis. Just going to move this out of the way. So looking at some of the online resources, just some reputable sites as far as, occupational causes, Pravesh went through the causes that are non-occupational, but what it's saying is that John Hopkins indicates that hip osteoarthritis can be from overuse. So jobs or sports that require physically repetitive motions that place stress on the hip, it can increase the risk of osteoarthritis. The Mayo Clinic indicates that repeated stress on the joint, so if your job or the sport you play causes this repetitive stress, it can eventually or may eventually lead to the development of osteoarthritis. The Arthritis Society of Canada indicated that people who repeatedly experience stress on a particular joint or who perform heavy physical labor may also be at a greater risk of developing osteoarthritis. They give examples of dancers, heavy machine operators, and construction workers. So in researching for this presentation and looking at the different occupations that have higher rates of hip osteoarthritis, some of the common occupations seen were healthcare, housekeeping, service industry, agricultural, fishing and forestry, mining, construction, and food service. So when looking at these different industries, some of the things in research that had in common as far as the risk factors that could lead to the development of hip osteoarthritis were heavy lifting and carrying, stair climbing, full body vibration, forceful exertions, kneeling, squatting, bending, repetitive arm movements, and standing. But one of the common themes out of all the research that was a huge predictor of hip osteoarthritis was heavy lifting and carrying. So the side here you see that I have a note that is important is that some of these studies that suggested that there was no increased risk of hip osteoarthritis with certain amounts of walking, sitting, and standing. However, there was a research that then also suggested. So it's important to kind of look at all of it, but a common theme across all the research that I looked at was this idea of heavy lifting and carrying being a primary risk factor in the development of hip osteoarthritis. So some systematic reviews that I looked at was Jan in 2024, who found that occupational mechanical exposure, so lifting, carrying loads, walking, climbing stairs, non-neutral postures, kneeling, squatting, standing, walking, and a combination of any of these seemed to influence the likelihood of developing hip osteoarthritis. Salsky in 2012 found that there was evidence that identified heavy lifting and standing as hazards for hip osteoarthritis. Umvers in 2024 indicated an association between various occupations with high physical workload and an increased risk of developing hip osteoarthritis. And Franzen in 2011, in a long-term exposure study, found that heavy lifting was a significant association in developing chronic hip and knee pain. In a longitudinal study that was 22-year prospective study that looked at risk factors predisposing for hip osteoarthritis, they gave a health survey in 1978-1980 and then re-examined these people after exclusions in 2000 and 2001 and found that hip osteoarthritis was diagnosed in 41 subjects. They found that heavy manual labor predicted the risk of developing hip osteoarthritis, and permanent damage as a consequence of any musculoskeletal injury was also an independent predictor of hip osteoarthritis. So when we look at all of this and we know that there is this risk factor of heavy physical labor or heavy physical forces that can lead to the development of hip osteoarthritis, we kind of go to this hierarchy of controls. The hierarchy of controls is an inverted triangle starting at the top with elimination being the most effective control, all the way down to personal protective equipment, which is the least effective. When we look at elimination, it's the removing of the hazard. Substitution, it was replacing that hazard with a lesser hazard. Engineering is something that can be built into the design phase. Administrative, developing procedures so the work is conducted in a way to minimize the hazard. So an example of this would be training. And then personal protective equipment is anything the worker wears to protect themselves from the hazard. For example, gloves. So when looking at the risk factors of hip osteoarthritis, the literature pointed in the direction of heavy lifting and carrying as a dominant occupational factor. So taking this into consideration, I then looked at different work sites I had been to and how, I could use this hierarchy of controls at each level and apply it. So in this example here, you can see someone bending into a gaylord, lifting out a pail of regrind plastic. So what they would do is every so often they lift this pail, and in the third picture here, you see a hopper. They would dump it into the hopper. And this process was done, probably a few times every hour, but it was causing some, musculoskeletal discomfort, and then, which brought them to, kind of seek some help. So when I went in there, one of the first questions you always ask is, why does this process actually need to happen? Does this, you're lifting it from one area to another area very close together. So the recommendation here was made to just have the gaylord of refined plastic be put in place of the hopper, removing the hopper completely and putting the vacuum right into the gaylord of refined plastic, eliminating this entire process from needing to be done. The use of substitution as a control involves replacing a hazard with any lesser hazard. So in this example, you can see the picture of bins to the right here. And this was in a donation facility. And what they would do is they would be getting a lot of different metals. They would organize the metal according to bin, and based on how full they felt, they could lift, they would then remove that bin from the rack and carry it over to a shipping area. So this idea of carrying and walking with different loads was flagged as a hazard potentially to develop some type of musculoskeletal disorder. So what was suggested and recommended was, I think someone is not muted. So what was recommended was that they then sort these into...
I'm just going to interrupt for a second, Melissa. Can everybody please be sure that they have their microphones muted, please? Because we can hear some background interrupting Melissa's presentation. Thank you.
Thanks, Dwayne. So the recommendation was made that the sorting be done directly into these bins, and then rather than carrying and lifting, they would then be pushed to the shipping area. Engineering controls are built into the design, and this is an example of a cart that had 500-pound weights loaded onto it. And what happened is that this worker was in a hospital, and you had to go and calibrate the scales throughout the hospital. As you can imagine, navigating the halls in a hospital, there's various patients, workers, equipment. So there's a lot of initial, stop and start. So with that stop and start, the greatest force is the initial force to get something to start in motion. And so there was a lot of initial forces being, in one path, just from point A to point B. The cart would stop several times. On and off elevators, there was that lip. So there was high forces deemed to be unacceptable. And the recommendation was made to then use a power cart rather than using this manual cart. Administrative controls do not change the hazard, but they regulate exposure to the hazard. So without making any physical changes to the work area, the equipment, the tools, or the work processes. One of the common administrative controls used in ergonomics is job rotation. So it's important, just like I said, that it doesn't really address any of the hazard of the actual job. It's just going to limit the person's exposure to that job. The important aspect in any job rotation to make it effective is to ensure that wherever you rotate, you're not using the same muscle groups in the same way again. The idea of job rotation, the premise behind it, is to give those muscles a break to regain, blood flow. They've fatigued already. So you want to go to some task that's different, uses different muscles. And you see in this graphic here from MSD Prevention, it's showing a manual material handling process where someone's lifting a box, and then, the next process they're going to go do some inspection and visual checks. Then they'll go do assembly. So you can see how the tasks are very different. And so job rotation can be an effective tool to use if it's designed and well thought out. Another administrative would be job enlargement, so increase the variety of work that the worker is doing, and then training. Personal protective equipment is something that the worker is going to wear. So it's the least effective control. Examples of it, the first one up here, the picture you see is a worker wearing knee pads. So they're protecting their knees against contact stress, which occurs when you rest a part of your body on the hard surface. So it's kind of it's giving them that layer of protection, but it's not changing anything about the hazard. Similar to the gloves worn here to protect against the vibration from the grinding of the tool. So again, this is kind of your lowest level of control. You want to ultimately try to eliminate anything that is going to be a potential hazard to a musculoskeletal disorder. So going back to a case study that I did with someone that had hip osteoarthritis, and just kind of to back it up a little bit, for many that might not be aware, is that OHCOW offers clinical service in which workers who have been denied any WSIB claims can have their file referred to our team. So our team of physicians, hygienists, ergonomists, nurses, CSCs, and we then review these files for work relatedness. So we're kind of combing through the files, kind of gathering evidence that although your claim was denied because they potentially said it wasn't related to the duties, that maybe in fact there is something there that really it was an occupational cause. So the study or the patient file that was sent to me was one of a police officer who had worked for 15 years at the time of injury and was diagnosed with hip osteoarthritis. The claim, again, was denied, similar to the one that you heard Trevor speak about and Cynthia, because it was a degenerative disease, it was gradual onset. It's a very common theme with almost a musculoskeletal disorder because typically it does take time. So often they get denied for that reason. So after all this literature I've researched prior, you see that heavy exposure to heavy physical loads is something that is a primary risk factor in the development of hip osteoarthritis. So when you look at police officers, they're required to wear a duty belt, which weighs approximately 20 pounds for the duration of their shift, which is typically 12 hours. This duty belt, it can range, and there's also other, they're wearing their vest as well. So they're carrying weight all day. So when I looked at duty belts in literature, I found that Burner in 2024 that duty belts have a negative impact on the officer's ability to perform occupational task and movement, and officers reported an increase in discomfort associated with wearing duty belts while seated. Billing in 2015 found that for every kilogram of load carried on the body, physical performance was reduced by 1%. Dempsey in 2013 found that duty belts reduced officers' agility and ability to exit, pivot, and accelerate from a lower car seat. 2023 found that 88% of officers reported pain and the discomfort at the end of the shift, and most of these complaints were related to the duty belt. Another study found that the most common area of discomfort associated with wearing duty belts were the hips and the lower back. And Larson and Ramstrom, who investigated gait kinematics at the trunk, hip, knees, and ankles when officers wore duty belts, found that there was greater hip abduction and abduction when the duty belt was worn. So taking this literature that was compiled, it supported the idea that physical heavy loads, including wearing duty belts, can contribute to the development of hip osteoarthritis. So that information was taken along with looking at the physical demands, the other job duties, their work history, and a report was written and submitted basically that the 15 years of exposure to these risk factors wearing the duty belt could have led to the development of the hip osteoarthritis. And with that, we can take any questions.
Thank you, Melissa and Pravesh. That was very, very informative. Okay, so the first couple of questions were placed in the chat while Pravesh was doing his talk, so I'm assuming that they would be directed more towards him. So other than changing sleeping position, what would be an effective treatment for a right side sleeper if the right side hip joint without OA has started exhibiting pain during walking? Should they look at a softer mattress? Or would there be other physical changes that they could do to help improve this condition? Pravesh, if you're speaking, I think you're on mute. Still on mute. Hold on here.
Can you hear me now?
Yeah, we can hear you now.
Okay. So in terms of the mattress, there's two things. One is your mattress should not be hard, similar to a doctor's examination bed. That's extremely hard. The opposite shouldn't be true either, like a pillow top where your body sinks into that and your spine is curved throughout the night. So it needs to be something in between where it's sort of firm, but not too firm and not too soft. Specifically, if you're getting hip pain, and the other suggestion is what we call a wedge. Some people will use a body pillow, but that's more big, or sometimes you can get a wedge that you can keep on your right side, so that prevents you from putting all your weight onto your right hip. That's specifically to sleeping. Then obviously, if you're talking about other things, then I think the analysis of the gait is vitally important. Whether it's coming from your ankle, your knee, or your hip, you can end up with hip pain. We see that fairly commonly. People with knee complaints ending up with hip pain just because the biomechanics have changed. Improper footwear and altered foot mechanics itself can result in people presenting with hip pain. So analysis of the gait, the footwear, whether you have a fallen arch or not, looking at the knees, all important aspects in terms of trying to find out non sort of medical ways to fix your hip pain. Hopefully that answers it somewhat.
There was lots of detail there, Pravesh. Thank you. What are your thoughts on PRP versus steroid injections?
The latest guideline from the American Association of Orthopedic Surgeons that did the literature review basically said it doesn't work. Long and short, don't use it. It doesn't work. So that's the latest.
Okay, thanks. One more for you. Which implant is the best when choosing between plastic, metal, and ceramic in THR surgery?
That's beyond my scope. I do not know that answer.
Okay, perfect.
I think ceramic is what they use commonly in our area, but I don't have any research knowledge in which is better than the other.
Okay, good. Thank you. I think this is for Melissa. What types of jobs in the service industry would be examples that cause occupational causes of hip osteoarthritis?
So the ones that the service industry that they really was, and I kind of doubled back on it, was Housekeeping was a lot. Even there were some mention of waiters, waitresses. You think of anything that they're having to carry, lift heavy physical loads, push, pull. Really, it was kind of a broad industry.
Okay, good. Did you find any differences, or are there any differences between females and males in wearing their duty belts?
No, I didn't. It was all just general. I mean, I could half assume that a lot of the studies too, it probably had more males, I want to say, than there were females wearing it. But no, that would be something to look at. I didn't notice any gender differences, and it didn't indicate any.
Okay. Do you have any specific recommendations on how to reduce the risk of hip OA from wearing the duty belts?
So there is research that there is a duty vest now rather than a duty belt. And it is suggested that it takes obviously takes the weight off the hips and allows for more mobility. And there's been research that shows that decreased complaints of our indications of discomfort and pain associated with wearing this vest compared to wearing a duty belt.
Okay, yeah, I've actually personally seen those vests, and they do seem to distribute all of the things that are on the belt a little bit more evenly.
Absolutely. It makes it more mobile too, even in their vehicles.
Yeah, I would be interested to see the negative repercussions of having that weight now pulled down on your shoulders, mind you. But
Absolutely.
I have to have the stuff somewhere, right?
Where there's one fix, there's always something else.
Exactly. Is there any role of welding work related to development of hip osteoarthritis? I guess better put, I'm assuming this question is, have you seen hip osteoarthritis in the welding trades?
I have not came across anything welding specific with regards to the hip.
Okay. Lots of questions here. Has there been any connection with those that sit for extended periods of time and hip osteo?
So in the reviews that I did, again, sitting was indicated as a factor in a lot of the studies as a contributor, but it seemed to be something that was more when it was in combination with something else. And just like I said, for every study that you find that supports that increased sitting can lead to hip osteoarthritis, there's one that says there might not be a connection there. So again, I think that's when you look back to the history, like what Pravesh was saying, like what other risk factors there may be, but there might be other risk factors on the job besides sitting as well.
Okay, perfect.
So just a further comment on that, I think the example Trevor gave of the sponge, when you don't allow it time to, resaturate again, if you just squeeze a sponge and you keep it squashed all the time, that's the static posture where your hip is not moving. So by not moving that hip, you're not allowing it to saturate and get its nutrients. So that would be one of the mechanisms possibly of why you increasing the chances of damage to that cartilage.
Perfect. Thanks, Pravesh. Thanks for that. Melissa, you mentioned the WSIB and employees who were denied from being injured at work. Can the employee request the WSIB send their file to OHCOW? Obviously, I know that answer, but can you explain that process a little bit more for this individual who asked this question?
Yeah, absolutely. So you can request access to your file. Typically, advocates, so whether it's like a union paralegal lawyer, would refer the file to us. However, you can refer. We've taken files directly as well from patients that without any type of representation as well. You would just need to have access to your WSIB file. I don't know if you have anything to add to that, Dwayne.
No, that was good. I think the individual was just looking for a little bit more clarification, that's all. You guys already talked about the standing and the sitting. One last one I can see here is there any chemical exposure leading to hip OA symptoms or related to the development of osteoarthritis?
Ooh.
What do
I
you think
feel
of
like
that?
that might be like a hygienist question. Do we have an OHCOW hygienist on here that
Yeah,
could potentially answer that?
the most commonest toxic chemical will be smoking and everything related to that.
Yeah, that's a good point. Okay, that's about it. I don't think we have another presentation. Do we have another one, Trevor?
Yes, we do. We have our final presentation today. It's entitled Implementing Motion Capture Technology for Ergonomic Assessments, and it's presented by Dennis Larson, a postdoctoral researcher from the University of Waterloo. Dennis, over to you.
All right.
Sorry. Dennis, you're going to have to unmute yourself.
There we go. I got automatically muted again.
Perfect. Thank you.
Okay. I'll get back to sharing.
Yeah, you stopped sharing too as well.
All right. How's that?
You're
That's
good.
good. We can see it, Dennis.
Perfect. Okay. Thank you for the invitation. As Trevor mentioned, I'm a postdoctoral researcher at the University of Waterloo in Ontario, Canada. And I'm also a practicing associate ergonomist with Pro Ergonomics, Inc. This presentation, if anybody had come to the Cree MSD presentation on January 27th, is going to be presenting the same information as that. So if you missed anything there, you'll get a review of the topic. But before I begin, I just want to acknowledge all of the collaborators in this project. This is a lot of work to work with all of these external companies to, what I'm going to present is going through these computer vision tools that are going to be used in ergonomics and doing some assessments on the workplace. So without all of their assistance, this data wouldn't have come together. So I want to send a quick thank you to all of them. And to start off, just kind of briefly going to overview a little bit of markerless motion capture and computer vision technology and how they work a little bit. So these technologies incorporate machine learning algorithms to identify key points of the human body from two-dimensional RGB videos or images. So across all of the tools that are out there, there are a variety of different methods to go from a 2D image to a three-dimensional posture or key point. So it's all embedded within their softwares, and they've all been trained with different videos, different data. So there are different models out there. And I'll touch on that in a little bit. But from here, they take a 2D image and go into 3D to create 3D points on the human body to create a 3D skeleton or stick figure that overlays on top of the body in the video itself. So just a couple quick examples of some multi-view or multi-camera methods. On the far left of the screen is Thea Markerless, now rebranded to just Thea. They require at least 6 cameras to see the participant while they're working to reconstruct their pose estimated skeleton on the body. And on the right is an example of OpenPose, which is an open source program that you can use 2 to 3 camera views to determine key points in 3D space. Now, in order for these camera systems to function, you need to perform a calibration procedure so that all the cameras know where they are in space and in relation to global space, and develop a relationship between the 2D pixel coordinates of the image and the 3D position in the world. Now, moving from these multi-view methods to single view methods. These are single cameras that are placed in the workspace or held by an ergonomist or practitioner, taking a video of the person, and they are then taking these 2D images, putting key points on the body, and pulling them into 3D space to get estimates of joint angles using just a single camera. And these don't require any calibration steps or procedures. Now, these single camera computer vision tools have rapidly emerged in the market, and these technologies are used to be like a simple point and record method of videoing workers on the job. And then you take those videos, upload them to their program or application, have it perform the human pose estimation, and then from there you get the 3D postures in space, and you can do all the risk assessments associated with getting those positions in space. Now, this can be used in a very quick period of time to get a very rich amount of data, both body position and joint angle wise. And this is data that we have struggled to capture in the field in a very time and cost efficient manner. And it helps ergonomists and practitioners better evaluate the risks in the field. However, like I said, it's a rapid emergence of these technologies, so there's many, many questions surrounding how to best use these technologies. And some of them that we tried to tackle with this project is there an optimal viewing angle for improved pose estimation accuracy? And an example of this is if you are in a larger company with multiple sites globally or locally, and you have two people taking videos of the same task, what if they're from different angles? How does that influence the pose estimation? How do we interpret the data and evaluate it to then do some risk assessments and find some solutions in the field? Another question is, does the speed of motion influence the pose estimation accuracy? Basically, if you're moving faster, there may be possibilities for image blurring, and that could influence the pose estimation accuracy. And the last one that we wanted to look at is that do outputs from differing computer vision pose estimation tools, do they differ in their accuracy compared to a lab grade system? So we set off to answer all of these questions in a study where we asked among healthy, able-bodied individuals performing a series of simulated occupational tasks, does the angle of video recording, the task pace, or the computer vision approach influence estimated trunk or shoulder elevation angles relative to the angles estimated from a lab grade system or approach? So with this study, we had 40 participants come into the lab. They did 6 different tasks. We had an above shoulder work task where they sorted tags above from pegs about shoulder height to above shoulder height. Cutting and trimming task where we simulated a meat trimming and cutting task that was designed based on a cutting block from Cargill. Simulated packaging task, putting cartons into a box, floor to shoulder lifting, palletizing, and cart pushing and pulling. So we did these 6 tasks. I'm only going to show a subset of 3 data points. So I'm going to show videos of them, those 3 specific tasks in a second. But we also did them at fast and slow speeds. Just to get, again, to answer whether there are some issues or potential issues with motion blurring. So just kind of a video of the above shoulder work here. So like I said, participants were sorting tags from the pegs that are at shoulder height up to pegs that are above shoulder height. There's 16 tags altogether, and they were timed to a metronome at both the fast and the slow speeds. For the simulated palletizing task, we had 10 crates being lifted from one side of the force plates that the participant is standing on to the other. Each of them were instrumented or had 10 pounds of weight inside of it. And they, again, moved at fast and slow speeds to the pace of a metronome. And then the last one that we're going to show today is the packaging task. So this is, again, paced to the beat of a metronome, where they picked up containers of Play-Doh, put them in a box, and then at the end of after they put all 10 in, they slid the box over to the left to simulate moving the box along a conveyor belt system. So during all of these tasks that we had in this study, we had 8 cameras that are synchronized all surrounding the participant all the way around the room. So we had some anterior, posterior, immediately sagittal, and then at approximately 45-degree increments in between those 2 extremes. Now, this is what those 8 cameras look like for the simulated palletizing task. And in order to get our reference data or ground truth data that we're going to be using in this study, we pre-process them through Markerless, like I said, which is that system that requires at least 6 cameras to generate a skeletal pose estimated skeleton on the body. So here's just what that kind of looks like from all the different camera angles. And I'm going to quickly show a video here of what it looks like during the palletizing task. Yeah, there we go. So this is just an example of the 3D pose estimated skeleton that is put on top of the participant doing the work. So this is a palletizing task, and this is just from one of the camera views that are on the left side of the participant. Now, each of the 8 camera angles, or each of the 8 cameras, all captured videos all at the same time. Like I said, they were synchronized together, and each of those videos were then uploaded and processed through 4 to 5 separate pose estimation companies. So here's just a quick example or quick picture of what those look like for the palletizing task. But I'm going to show some videos here of what each of the companies, of the 5 different companies that we used, doing that same palletizing task. One's a little bit out of sync there, but one thing I want to point out here is that all of these companies, like I said, they all have different, are all set up differently. So they try to identify key points within the body. They use the key points in slightly different ways in order to generate their skeletal pose estimation and calculate their joint angles. And they're all trained off of different data sets as well. So this creates a little bit of differences across these pose estimation companies. And I'm going to get back to that again in a little bit as well. So for the comparison, we extracted shoulder elevation angles and trunk flexion extension angles from our Markerless data set. So we took our video, uploaded it into Visual 3D, and then from there we calculated the shoulder elevation and trunk angles. And we asked all of the companies to calculate these same angles for each of the camera views that we uploaded for them. So we got the shoulder elevation and trunk angles from the pose estimation companies, and we compared them together. So this is just an example graph here where we have angle along the y-axis, data frames, or the time that the trial was going on for. Thea data is in black, and then just an example of the different camera views. Here's the different colors, green, red, and blue, representing each of the cameras compared to the Thea. So from there, we determined root mean squared differences between each of the camera view companies and the Thea Markerless data set. So I want to point out that in this field, many researchers would coin this metric or this term as root mean square error, but we are calling it a difference for this study. And the reason for this is that the skeletal or stick figure pose estimation overlays that are estimating our position of our body in space, they're estimating also the position of our underlying skeletal structures, and they may not be exactly replicating the movement. And this is the same for an optical motion capture system as well. You have the reflective markers put on the body, on bony landmarks, but you still have skin motion artifacts. So it's a representation of the movement. It is not directly the skeletal movement that we are measuring. So because of that, anything that deviates from our Thea Markerless data is a difference in this study compared to classifying it as an error. So we're going to hop into some results here. I want to point out before we get any further that we are in the final stages of processing, double checking the data for one of the companies that we were working with. And this project was started over a year ago now. And it's for all of us, we didn't fully understand the sheer amount of data that we would be working with at the onset of this project. So incredible learning experience. Got over a few roadblocks, almost done with the project, but the data that I'm going to be presenting here is a subset of 3 of the companies instead of all 5. So it's just a representation of the trends that we are seeing so far that are still being seen in the other 2 data sets. We're just finalizing those analyses. So first, we're going to look at shoulder elevation angle on the left side of the body. And we're going to specifically do it for the above shoulder work task. Now, before getting into any of the graphs or any of the data, all of the figures that I'm going to be presenting are going to be presented very similarly. So we have root mean squared difference along the y-axis. We have all of the camera angles along the x-axis, starting from anterior, working around the left side, going all the way to the right. And then there's going to be 2 different color bars. The dark blue bars are going to be fast, and the light blue bars are going to be considered slow. So this is going to be the setup for all the figures moving forward. And again, this is going to be the left shoulder elevation angle for the above shoulder work task. So the first thing I'm going to pull up here, this is for the left shoulder, taking the camera view from the left side of the body. This is where we saw the lowest differences between the Statham Markerless data and the 3 companies that we used in this initial analysis to look at the trends. So what I want to quickly point out, so it's around 10 degrees of root mean squared difference. And before I move on any further, I'm going to step back a little bit and maybe address a little bit of elephant in the room regarding this 10-degree difference that I just mentioned. So in this graph here, I'm going to show you the left shoulder elevation angles for the above shoulder work task. And this is just a representative trial for this task from the left camera view that we just talked about. So here's the reference Thea data for the left shoulder elevation angle across the trial. And what I'm going to start doing is populating the graph from all 5 of the companies that we looked at. So I'm just going to start slowly populating these in here. And as we go through and add more in, just looking at the general offsets and biases that some of these data have at certain time points throughout the trial. Some of them being above our reference data set, some of them being below, some of them are going above and below at certain points as well. So going back to what I mentioned previously about how these different companies work, or these different pose estimation algorithms work, we believe that these general offsets and biases are due to how these companies are calculating the joint angles themselves in relationship to how we calculate the Thea Markerless data set. So what do I mean by this? Now, Thea requires a multi-camera setup with the video and image data from at least 6 cameras to generate the 3D pose estimation. So with all of this data, the Thea system can represent body segments like the upper arm, the pelvis, the torso, the thigh. They can use or represent these with 3-dimensional coordinate systems, of which they know the position and orientation in space. And from there, I can calculate the shoulder elevation and trunk flexion extension angles following ISB standards, which many researchers use to calculate angles. Now, with the single camera pose estimation data, they may or may not potentially use some open source computer vision approaches like OpenPose or MediaPipe. So those are open sources that they can use to start building their computer vision algorithm, or they've developed their own algorithm. But they've all kind of share a similarity in that they are looking for key points on the body that are different than what they can use with the multi-camera system. So they have built and trained machine learning models to pull these 2-dimensional key points from these videos into 3D space and create 3D coordinates and calculate the angles between these different vectors that are created between these points along the body. So it's a little bit different in how Thea Markerless does it. So while we best matched our calculations between the Thea data and the computer vision company definitions, the way we are calculating them are still inherently different, which leads to some general biases or offsets between the computer vision company and the data that or company data and the data that we collected with Thea. So that's again a reason why we're calling them differences as well. So jumping back to the data that I just mentioned about, or jumping back to the original data that I mentioned with the 10-degree difference between Thea and the 3 computer vision approaches here, we now have what we believe is an explanation for the general root mean squared difference that we are seeing between the companies and the reference data. And now I want to focus in more on the factors such as camera angle and movement speed that may influence the overall accuracy of the single camera computer vision data. So again, this is our best view. Going to the other extreme, we have the worst view. So this would be from the anterior right, where we are seeing larger differences between the Thea Markerless data and our reference and our computer vision companies. Now, the reason for this is that we can see that this is the camera view here from the anterior right-hand side looking at the task. There's partial body occlusions on the contralateral side. So if we're on the right side looking on the left, we're having a hard time seeing the left shoulder, left upper arm to generate those angles. So then we're having these greater differences being generated between the reference data and the Thea Markerless. Now, all the other bars that I just populated in here, they are somewhere in between. So we can see that there's a range looking at the left side, left shoulder elevation from the left side, and then we see greater differences when we go from the right side looking at the left shoulder angle. So the key takeaways from here is that a side view of the plane of motion that is the major joint of movement, so flexion extension in this case, is performing best. So if we are taking the camera view from the left side, left camera view, we're seeing that as working the best. We want to avoid occlusions because that leads to greater differences and not being able to track the motion very well. And then what I didn't point out is that you'll notice that all the letters on the different bars, if they're different, that means they're statistically different from each other for camera angles. And then the asterisks above those letters, that means that there was a statistically significant difference in movement speed. So for some of the, I'm going to call them non-optimal camera views, the ones that are not highlighted in green, the slower pace resulted in larger root mean square differences in those scenarios. Jumping to the right shoulder elevation for the above shoulder work task. So the exact same task, but just looking at the right shoulder instead of the left. Here on this side, right, or the camera angle or camera view from the right side perform best. And looking on the left side or the anterior left perform the worst. So these are just similar results, but just flip to the right side of the body. So again, I'm going to populate the rest of the bars in there and everything is in between. But again, the key takeaways here, perpendicular view to the plane of motion results in lower differences between the Thea data and the computer vision tools. Avoiding occlusions again, that is always, if you can't see it, it's not going to track it well. And from here, if we take the left and the right side data together, it shows that we need to record motion on the same joint of interest in order to optimize the results of our computer vision tools. So just quick summary of all of that. Key takeaways so far: video recording angle matters, and there seems to be a limited influence of movement pace, specifically when you look at the videos recorded from the optimal views. Okay. So now we're jumping to a different task here. So the above shoulder work was very stationary, looking straight ahead. Palletizing, we are having rotation of the body, turning back and forth. So we're just going to look at the right shoulder elevation angle for palletizing. Again, the graphs are going to be set up the same. For this task, both the left and the right side produce the lowest root mean squared differences, or differences between Thea and the computer vision tools. And then the anterior and the posterior views presented the greatest differences between computer vision companies and our reference data set. So with that being said, again, we're key points here from the side. We're seeing that we're having the greatest plane of motion, the flexion extension of the shoulder elevation. And when we go to the anterior side, we have those pillars of crates in front and behind that lead to some potential occlusions in the body, and then some greater differences and tracking errors, or tracking differences between the computer vision tools and Thea Markerless. And then the other camera angles kind of fill in the gaps in between. So again, from here, key takeaways, like I said, perpendicular view of the major plane of motion is performing best. And here we're also seeing at those non-optimal views, we're seeing that slower pace is generating some higher RMSD values. Now looking at the trunk angle itself, or the trunk angle during the palletizing task, we haven't looked at that yet. We looked at flexion extension here. Again, looking at the left and the right side, we have the lowest RMSD, but here we're also seeing the anterior right as well. And this may be because some companies have been trained to look at data that way. So that could be resulting in some of the anterior right being involved in the lowest data or lowest differences here. And then again, the anterior and posterior side, we're seeing those largest differences occur there as well. And then the other two camera angles fill in the gap. So again, when looking at the key takeaways again, perpendicular view, major plane of motion, lower root mean squared differences or differences. So we're having these better pose estimations of those data when we're looking at that sagittally or the side view of the major plane of motion. And there's limited influence of the movement pace on these optimal views. So just to come back, key takeaways here, video recording angle matters, limited influence of movement pace. Again, the movement pace is for those optimal views. So when you get into the suboptimal or non-optimal views, you're starting to see that movement pace being a little bit more of an influence there. So last little bit of data, I know I'm throwing a lot of data at you. This is only a subset of everything that I've been looking at, but here's the right shoulder elevation during packaging. So again, we're looking at the right shoulder, looking at the right side of the body, or having a camera on the right side of the body, we see the lowest differences there. And then on the anterior or anterior left, so looking opposite to where the limb of interest is, we're seeing those larger differences happen there. And again, pointing it out here because it's really clear, those non-optimal views, you're seeing that difference in movement speed, where on the right or that optimal view, you don't see that difference in movement speed. Then the rest of the camera angles or camera views kind of fill in the data in between. So again, sticking back to our key takeaways, side view, major plane of motion, same side of the joint of interest. That's the exact same results that we're seeing with the above shoulder work tasks. So we're seeing it with across multiple tasks, as I just pointed there. So we're seeing the similar results across multiple tasks and starting to build a story here. Last little bit with the trunk angle packaging. Here, it gets a little bit different, but there's a reason for this, I think. So with the trunk angle and packaging, the camera angle with the lowest root mean squared difference was the anterior right. And now for this, we were tracking flexion extension. And if you look at the image up in the top right, as the participant is reaching to grasp the containers, they're twisting their body, and their major plane of motion is now in line with that right or anterior right camera view. So again, being sagittal to the major plane of motion. So because we're looking at trunk and flexion, the sagittal view, and as we turn, we're facing that anterior right camera. I think that is why we are seeing this be the lowest or have the lowest difference for this trial or this data. Now, the worst in this scenario is posterior right. So this is looking, if we twisted our body, camera right behind us that way, we're looking at the frontal plane. We don't see the flexion extension axis very well in that plane. So again, we have the greatest differences there. And then all the other camera angles come into play here. So again, key takeaway, camera angle perpendicular to the major plane of motion, performing best. Now, with this one, the speed differences are slightly different compared to everything else that I presented. So we're seeing slightly greater root mean square differences in the fast-paced movements across most of the angles for this one. But again, what I'm looking at here is if I compare all the means across these data, while it's statistically significant, it may be a degree or 2 degrees difference between fast and slow. So the practical implications of this are not large. So again, coming back to the key takeaways, kind of hitting the nail on the head a little bit too much here, or just repeated. Video recording angle matters. Limited influence movement pace, especially if we record from those optimal views. And before I get into a little bit of a summary, I just kind of want to show an initial comparison across the companies. Again, just to kind of show that we're seeing it across all the companies that we've been looking at, and not just 1 or 2 companies driving the data that we're seeing. So this is an initial comparison across companies. This is going to be focusing in on the left shoulder elevation angle from the views on the left side of the person. So kind of narrowing our scope a little bit. And for the palletizing task on the left, again, across all of the companies, we're seeing that the left camera angle is generally producing the lowest root mean square difference across all the companies. Going to above shoulder work, so the graph on the right, the left side producing the lowest root mean square differences or differences from the companies compared to the Thea Markerless. And again, that's generally across most of the computer vision tools. So we haven't done any statistical tests between computer vision companies as we are still processing that part of the data, but that is part of our analysis going forward. So again, key takeaway here, similar results in interpretation across the 5 different companies that we've been using. So if we add that in to our key takeaways, we see subtle differences, but similar results in interpretation across the companies. But again, we're still analyzing a little bit and haven't run any statistical analysis. So this is the results so far. So what does this all mean for ergonomics now? So using these computer vision tools, went a little bit ahead there, is not as simple as just point and shoot. We point, capture, upload a video, boom, Bob's your uncle, you have a completed risk assessment, you have your answers, go from there. It's not as simple as that. So with everything that we've learned and presented so far, capturing good quality data will allow you to perform some risk assessments. And you also require the appropriate training and guidance to capture that data appropriately and to interpret the data appropriately as well. So the saying that I like to use is kind of good data in, good data out, or bad data in, bad data out. So if we are using everything that we've learned, capturing good quality data, using that as inputting that into these computer vision tools, we can then do some assessments that way. Alongside this, part of our goals with the study is to create a best practice guidance document or infographics to help users best understand how to use these computer vision technologies to capture these good quality data. So once we have everything wrapped up, we're going to be working on these documents as well, and just to get the best practices out there. Now, also in what's happening now is we're seeing a lot of these companies integrating existing single task assessment tools like NIOSH, Strain Index, REBA, RULA, Liberty Mutual Equations. Starting to see a little bit of hand activity level as well, depending on the company. And while these assessment tools are mainly posture based and do require some inputs such as like hand height, vertical displacement, frequency, duration, etc., I believe that these technologies are working to help companies, ergonomists, and practitioners perform these assessments in a more automated way, and in hopes of freeing up some more time to focus on creating those solutions. So again, it's not as simple as point and shoot. And again, you get the data you want. You need to have appropriate training, guidance, capture good quality data, and be able to evaluate and interpret the data and risk assessments that are coming out of it, and not just take it as gospel. That's what I'm trying to say. So in principle, I think this is a great step for ergonomics now. But again, like not simple as point and shoot, and requires some good data and good guidance to capture that good quality data. Now, before I talk about how this technology can be used in the future, I kind of want to put this in context with some previous work surrounding a 2.5-year long Ontario University's back pain study. Now, this study examined physical and psychosocial risk factors associated with low back pain in workers from General Motors Canada. And in the study, they captured videos of workers on various jobs on the production lines. And they set up these cameras to view the major plane of motion, which was flexion extension, and they set them up to view from the side. So again, similar to all the results that I presented here, this is just going and backing up research that was done previously. So our data is suggesting the exact same best practices as what was used in the past. Now, all these videos were digitized, and an operator or an assessor used a computer program to manually enter the postural information to match stick figures and postures with the video that was captured. And they did this frame by frame. And this is very, very time consuming. Now, from this work, many seminal studies use this data set to identify several biomechanical factors associated with reporting low back pain. Some are peak and cumulative spine loading, peak spine flexion, flexion velocity, etc. These are very influential works, and they no doubtly took a long time to collect and analyze and process, and especially going through all those videos to capture and posture match frame by frame. But now what I'm bringing this back to is now in the future, what this technology means for us now is that we can have the ability to capture these time series data in the workplace and analyze these data in both time and cost efficient manners. Again, when these data are captured using the best practices approaches that we are continually learning about, it can lead to the development of extremely rich databases of movements outside of just lifting or flexion extension that occur at various jobs that can be used in further epidemiological work to identify and characterize injury risks in the workplace. And one of the areas of immediate interest is trying to quantify cumulative loading exposures for joints throughout a workday or work shift. Now, with the landscape of modern work changing to involve more multitask work or trying to measure cumulative exposures across many different tasks, if there are job rotations, it is becoming increasingly difficult. And using the single task assessment tools to take snapshots of each and try and put them all together is very time consuming. However, we believe that this computer vision technology can be used to capture time series data across multiple different tasks, and then can be used in modeling approaches to estimate cumulative loading, exposures that are on specific tissues of the body, estimate some fatigue development over multiple different tasks, and kind of work in some of those more cumulative loading exposures and risk assessments in the field. Now, before I turn it over for any questions, I just want to quickly summarize and remind everyone that these computer vision tools have been built on machine learning algorithms to identify key points on the body. These models are a continual improvement process. As we feed it more data, they're going to learn more about the data, get more accurate. And given the recent and continued advancements of these technologies, I would argue that we are still in the infancy or early childhood phase of these technologies. And as they learn and continue to improve, or they will learn and continue to improve as we continue to use them. So again, this is just it's a newly emerging tool. A lot of information that can be captured very quickly, and I think that can be used for very useful research in the field, and taking that field data and finding or applying it to epidemiological research to get some more risk assessments in the field. Now, with that, I'd like to thank the team for all their work in this. Thank all of our collaborators, and I'm opening up to you for any questions.
Great, thanks, Dennis. Before we actually start the questions, just a reminder to everyone, we are going to be posting the Slido survey post questions. So if you can please take a moment to answer that while we ask the questions to Dennis. So Dennis, the first question was, it's interesting that the root mean square difference was worse in moving slowly. Any hypothesis why?
Yeah, this was a little bit perplexing for us as well when we initially looked at this data. So with I can't remember if I mentioned it, but the fast trials are, fast trials are double the speed of the slow trials. So effectively, the amount of data within each of those trials is doubled for all of the slow tasks. So that means there's double the amount of data points, double the amount of chances to be different compared to Thea. And I think that is what is essentially driving those slightly higher differences for the slow data set compared to the fast. Now, what's interesting is maybe if we time normalize to similar amount of data points within each, that could potentially take away that differences. But yeah, we haven't looked at that yet. It's something of future interest.
Based on what you've seen, any recommendations on technologies that could be used based on their data source for workplace applications?
Just maybe a potential clarifying for that. Each of these companies are being used by many corporations incorporating these computer vision technologies into their ergonomics applications. All of them have slightly different tools that they're building into their, I'm going to call it their ergo application. So when you're looking to figure out which one is going to be working best for you, I would just contact them, see what technologies they're working with. Is it going to fit into your ergo program? Some of them are more performance-based. Some of them are more of a systems-based approach and time measurement. And some have incorporated different static ergonomic tools within them and are trying to work on validating. So they're all at different stages. So it just kind of requires a little bit of exploration to figure out what is going to work best for you.
Okay, great. From a practical approach with prevention in mind, rather than research, do you recommend these phone-related tools to create an understanding regarding which vocations, positions, or tasks pose the greatest ergonomic risks?
Yeah, I think that this could be a very valuable way to collect what I'm going to call big data. That's kind of a term that is kind of being thrown out a lot. We have really had limited access to capturing time series data within the field in time and cost efficient manner. So just thinking if we want to do this now without the computer vision approaches, we would have to bring in an IMU suit or inertial measurement units or multiple cameras and set them up and calibrate the system. This is ultimately going to slow down the production processes, and many companies won't allow that. But having this quick tool in there will allow us to capture that time series data, which can then be put together from multiple tasks, multiple workplaces, and then we can potentially in the future start to look at some relationships between injuries that are being presented in those fields with the motion that's happening. So it's a long-term outlook for how these tools can be used to look at injuries in different workplaces and different tasks and across different sectors as well.
Okay, great. Well, thank you, Dennis. That appears to be the last question. I look forward to seeing what's coming in the near future with respect to all this technology, as you and I discussed earlier. It could be almost ground changing, or it's almost scary what we could be seeing happening. So, with that said, Dennis, I'd like to thank you for participating today, and also thank you everyone for being here. And hopefully, we'll see each other again next week. Oh, and just a reminder before you leave to finish doing the survey as well.